Introduce to you the Acting Practice Manager for IPC Health in Deer Park. Please welcome Jessica Chung.
Hello. Hi, everyone. Like Marissa said, I'm Jess. Thanks so much for having me on today. Marissa and I have worked together very recently to basically, give education to the community about the vaccines for COVID-19. And as we're aware, and as you all probably feel quite a bit of, hesitancy around getting vaccinated because it has been changing a lot. There's a lot of confusion out there. There's lots of concerns. So I'm here to address some of those concerns for you.
This meeting is
definitely
being
not
recorded.
here to say, go get vaccinated, pro-vaccination or don't get vaccinated. Simply here to give you all the information for you to make an informed decision. But obviously my disclaimer is that I'm not your regular GP. I'm not a doctor, so I can't say, speak, in regards to assessing your individual risk and benefits. But certainly we'll go over everything generally. And so it will just be an open forum today as well. So I'll start with going through, what are the main, things that's going on at the moment for COVID vaccination. So the vaccine itself, the rollout, the program, how it's tracking, and obviously address the concern with the blood clotting, which we all sort of, I'm sure, have questions around. And then we'll just keep it as an open forum for everyone to ask questions and see where it takes us from there, if that sounds okay. So I've been a registered nurse for over 10 years, worked in across different areas. Started off in emergency at the Alfred Hospital, so worked there for about 5 years. Then started feeling a little bit burnt out in the hospital and showing up to work in the four walls. And I didn't feel that sense of reward for your job because it was just a fast-paced environment. And then I transitioned to community health, so started working in a general practice clinic for a couple of years, and then I worked in fertility with women and women's health, and then went back to general practice nursing and have been working with IPC Health, in the Deer Park GP clinic for the last 3.5 years, and I'm never looking back. So I'm really passionate about community care. There's a great sense of reward when you get to know patients. You're actually helping patients where they, to live more healthy and, and prevent them from going to hospital, preventing them from getting illness, disease, that sort of thing. So that's where I'm at. I've been acting in this role as a practice manager for the last 10 months. And so my role, obviously, to manage the day-to-day running of the clinic, but also I have basically rolled out the COVID vaccination program in our clinic. And so this has been running since the beginning of April. So I help train the staff there, the nurses, the doctors, be a guide for sort of our senior management, that bridge between sort of the medical advice and, our policies that we need to work around. So I can certainly understand the, I have a really good insight and grasp on the actual program itself, but through, speaking to patients, through working in the COVID vaccination program myself as a nurse, writing the policies and getting out there, speaking to clients and through community engagement programs, I have, a good understanding and a real sense of, the messaging and especially the mixed messaging that's going on that's causing a lot of concerns and hesitation. So let me start by saying, the rollout of the COVID vaccination, obviously it was, the most welcome news because it was, this was our fight against COVID vaccination. So, if you all remember back right at the beginning of this year when everything was announced, there was, we were all very pleased to hear it. There was, the reasons why the COVID vaccination was the process in testing, in trials, it was so sped up is because basically, the whole world, we've been faced with a pandemic no one's ever faced before. So when they do trials, it obviously takes time, but because of the pandemic, companies governments have poured so much money and resources into this program to get it tested, to have doctors, from scientists from all over the world on board in this program. Trials usually take different phases. So they have phase 1 trial, phase 2, phase 3, and in between each phase, they usually have a break. They have to wait for funding to get approved, enough participants to recruit, and they go on to the next phase and the next phase. But obviously, in a COVID pandemic world, we were not in short of having participants, and people put their hand up to say, hey, I'll be the participant to get this vaccine rolled out so we can save human lives. People just dying all over the world. So that's one of the reasons why obviously this COVID vaccination development of it has sped up and came to our shores and was introduced to the world as quick as, I think it was just over a year it took. So in saying that, there was only a limited number of vaccines that were successful through all these processes. So in saying that, in Australia, we have the TGA, so it's the Therapeutic Goods Australia, and also ATAGI, which is the more sort of immunisation specific sort of medical body that they're independent from the government, but they give the government advice about any medicines or vaccinations that come to Australia, or and they need to approve its safety. So Australia's got like the highest standard in the world for safety. Now, so taking you back when we just received these vaccines, we were, as the rest of the world, is fighting for these vaccines. So a handful were made available. So, you may have heard Johnson & Johnson's, you may have heard Moderna, Pfizer, and obviously AstraZeneca. So those are the two, AstraZeneca and Pfizer, are the ones that made it to our shores, were approved. The government secured the deal very, very early on, to sign, $1 million deals to secure the vaccines and to manufacture them in Australia, thinking about, obviously Australia's health and wellbeing. We need to secure before that they're even approved, and we knew which brand we're getting. The government had signed a deal with these big, giant, pharmaceutical companies. Now, so, there's the background information and, trying to put into context about the rollout. Now, obviously we had to start off with, our most vulnerable people in the community. So our age, we started off with the over 70s. We started off with, frontline healthcare workers. And right at the beginning of it, as you can imagine, it also rolled out, before Australia, it was rolled out in the UK. But, as the government has picked up, the side effects that were reported, it was very, very new, this syndrome called TTS, so thrombocytopenia syndrome. So I'll talk a little bit more specifically about that later, but basically little bits and drabs came out with new cases, and it was very unknown, and it's a rare, it's very different clotting mechanism to other common types of blood clots that you may, think that it's related, such as, heart attack and stroke. It is very different. So as the data came through globally, and in Australia, the government has obviously realised that, there is some connection, and that was confirmed through blood test of those people who had the clots, who went to the hospital. Blood test confirmed that they had low platelets, and that's, as well as a blood clot. So that's why it's a very unique syndrome that they identified related to AstraZeneca. So my point in sort of explaining all this and to the lead up of it is that because this was, it's an unprecedented event, pandemic. The pandemic, no one could foresee that was going to happen. The demand for vaccine globally, because there were deaths. We didn't have any, choice in, which brands we were going to secure. And obviously no one could foresee this TTS syndrome, this blood clot, was going to be a rare side effect of AstraZeneca. So the confusion amongst everyone now, and what I hear a lot is that, we don't trust the government anymore. Why is the government chopping and changing? Why didn't they just change it from the start? And basically, it's through the peak bodies, the peak medical bodies. What I say is like they are assessing the evidence as it comes through. So previously, the cases of TTS and the blood clot syndrome were mainly the majority, and I'd say about, I think 90% were found in those under 50. So hence the data reflected that, look, we need to change the advice because the majority is happening under 50. We'll change the advice to say we'll restrict it to, under 50 Pfizer and over 50 AstraZeneca. All right, and obviously with the most recent cases, they did show that there were people in their 50s with, who developed this blood clot. So hence the advice changed again. And it's like, well, do we want it? Do we prefer our government to just hide that and just carry on and say, well, we don't want public distrust and we'll just carry on and vaccinate everyone that's under 60? Or is our government going to be transparent, which they have been from the beginning, and just altered and refined the advice as we went along, as new data came along? Because we've got the new cases with people in their 50s, hence the advice has changed. I think when we think about our risk and benefits, we have to think about, well, it's not the fact that the government is picking and choosing, or deliberately picking the least effective vaccines for Australians and they can't change it. Well, basically they're not. So the week before, or the 2 weeks, as you all recall, the 2 weeks before the government changed the advice, we obviously had community outbreaks. And there was unprecedented demand on all COVID vaccination clinics across Melbourne. And you would have seen it on the news, really big lines at the city. At IPC Health, we have obviously our programs, and it was just crazy and manic. People were calling, the phones didn't stop. And so during that week, the government actually doubled all our allocations for the AstraZeneca vaccine, because the GP community clinics were only allowed to stock AstraZeneca and not Pfizer. And even before that, as you know, there was sort of hesitancy for people to come forward and get AstraZeneca. So the government doubled our doses. So, if a clinic ordered 200, they'd get 400. If we ordered 300, we'd get 600. And so that's what happened those 2 weeks before the government changed advice. So had they had, at that point when the government makes the decision about what should we do now, we've got evidence of people in their 50s who've had the blood clotting. We've just started to gain community trust. People are now getting the COVID vaccinations. We've allocated these vaccines to the clinics. They do sort of have a point where they can, just say, okay, well, we'll just keep going with the program as it is, or we're going to make a decision based on the latest health advice and the evidence, and then just scrap that and then, give new advice based on the evidence, to follow the safety advice. So that's what they did. So this is just sort of a little bit of an insider on sort of what happens in the vaccine delivery program and how the government makes decisions. So, just to give you an insight to say, okay, the government, I don't see that, working as an insider, I see that they really do just make decisions as they go, because no one could foresee at the start that we're going to get AstraZeneca and this would happen. Because obviously if they did, they wouldn't have done that. No one could foresee it, but they are doing their best and giving advice as new evidence emerges. So I think that's a positive thing. And also I think our jobs as health practitioners is obviously it's definitely not, we have training and we have a lot of emphasis about listening to the patient's concerns. We're all not here to say, come on, you have to get, you should get it, it will be fine. It's actually about firstly listening to the patient's concerns and really acknowledging it, because the media tends to show things, all bad things. The cases of TTS at the moment is currently in Australia, there's 60 cases. but there's 3 million people who've had the AstraZeneca in Australia without any serious adverse effects at all. So if you look at that statistic, it's still very rare, but of course we live in a world where we don't really hear about that news, or maybe you see it somewhere, but it doesn't sort of stick in your head. You just hear about those few cases and we get worried. And the second thing is that, like I mentioned before, TTS it's something very new. It's a syndrome connected to the AstraZeneca. At the start, no one really knew much about it, but now all the doctors and physicians have, obviously they take bloods and study, all these people who've had the syndromes, and there's a lot more information out there for doctors and nurses, general practitioners in the community. So we all know what to look out for. We all educate our patients. So after you have a COVID vaccination, you will have a pamphlet, patient information, and it actually talks about TTS. So it's very transparent. There's nothing that, it doesn't say. It does say that there is a small risk. It lists the facts there, the statistics there, but it says, these are the symptoms to look out for. If you experience any of these symptoms, you seek medical care straight away. And so TTS is actually a very treatable condition. Like any other blood clot, it's very treatable, and they may, I haven't looked into the specific treatment, but it may be one of the treatments where they just give an injection to thin out your blood to help dissolve the clot. So don't quote me there in terms of the exact, but it is basically very treatable. So, risk, in terms of talking about risk versus benefit. So people who are in the age group over 50 years old, if you get COVID-19 infection, you have to think about, if I get COVID-19 infection, will I possibly be hospitalized, get really severe disease, possibly die from it? Or if I get a blood clot, I have pain, because the first sign of a blood clot is pain. When people get a heart attack, they start getting chest pain. If they have a stroke, they start getting pain or headache in their head. If you get a blood clot in your leg, you start getting pain. So it's the first sign, because the blood clot is blocking the blood and causing ischemia, which is just low blood flow to the area, and all your pain, pain sensors, and, it induces pain. So if you get a bit of pain, which is unusual pain, you call the ambulance, go to hospital, you get treated. But if you get COVID, you would have already infected your whole family, because you're infective 2 days before you get any symptoms. You've infected possibly your family, most likely, I guess. Everyone who gets infected with COVID, it's about a 90% chance they'll infect their house members, because they've been infected for the last 2 days, not knowing. And, they have best efforts to separate, use different bathrooms, so that eventually you're in the same household, you're going to get it. So, that's the risk. The risk is that you've already been to all over the shopping centre, you've been to other people and then have transmitted the virus to them before you even knew about that before you even felt symptoms, got tested and found out you were positive. So there is a greater risk to the community, not just yourself, if you contract COVID. And then you're contracting COVID, and you could pass it on to someone who's immunosuppressed, elderly, and obviously the greater risk is for them. Not to sort of put that sort of weight on you, but that's the reality. And, I think anyone over the age of 50 is definitely at higher risk than someone who's younger and contracts COVID. You can obviously be hospitalized and result in death. And last year we had quite a few people in their 50s, in the peak of the pandemic last year, die from COVID. So I guess, that was sort of the vaccine rollout, and going into sort of the perspective of policy changing and why it was changed. So I guess, the current advice is now that, it is, the risk, if you're, and that's the thing, it is, the health advice is not perfect. It's not it's not 100%, foolproof. It's not 100% guaranteed. It's the best advice and latest advice that we have, because this virus hasn't been around for long. It's actually very new. And sometimes, even though we all want, we're all dying and really want a guarantee and the best answer, unfortunately that may not come, and if, you know, say if we're you know, for an army who's you know, a troop who have been wounded at war, are they going to take the antibiotic that they've got on hand that might be 50% effective? You know, because that's all that's left, that's all that's available, or they're going to wait, you know, another 7 days before they get to another antibiotic that's, you know, 90%, going to be 90%. Sort of like, you know, you have to sort of sometimes think in a bigger perspective, you know, of the situation in the world and with what we've got. You know, and the health advice isn't saying that, you know, if the blood clots were very serious and is causing death at a you know, at a rate and you know, and causing mortality, the health advice would actually stop and say, no, this is actually causing a threat to human life, and the risk is greater than COVID itself. But it's actually the other way around. The threat of COVID infection and a pandemic and wiping out our elderly and vulnerable is actually much, much greater than a blood clot that can be treated and has a lower risk of being fatal. Yes, so that's the part about COVID and risk and benefits. So, you know, the hardest thing as a health professional as well is because, you know, I do understand the community perspectives. I do understand, you know, patients talking to me about, you know, their fears and, you know, the uncertainty and the changing advice. And, you know, and basically, you know, I'm educating and I'm giving them the pros and cons, and I'm giving them the risk versus benefits and everything. You know, for a couple of weeks later, all us professionals, you know, just a couple of weeks ago, we're like, yep, it's okay. I think, you know, we're following the advice and it's okay. You're in your 50s, you should get it. And then 2 weeks later to say, okay, it's changed, you shouldn't get it. So we feel bad as well, you know, saying this a couple of weeks before and saying this is something else. So we do, you know, we want to convey that we really do understand, we do really get, and we don't sort of, we respect everyone's thoughts and worries and concerns around that. But at the same time, we follow, we look at the evidence, and everything is very evidence driven. And we're very lucky to live, I guess, in Australia where, you know, it's we're not pressured by government as such as in other sort of, you know, countries. You know, we're very transparent in our government. You know, there's no, you know, there's no cover up as such. I mean, you know, there's always groups and people who think, oh, there is a cover up, but generally speaking, that basically it isn't. Nothing's covered up. It is very transparent. So when that week, you know, when we had to call patients because the health advice changed, that AstraZeneca is now recommended for over 60s only. The 50s, so the 50 to 59 cohort, we had lots and lots of patients booked in. So unfortunately, obviously, we had to call them and cancel. And it was really tough because they said, these patients said to us, well, okay, well, where can I get the Pfizer? Where is it available? And unfortunately, it wasn't available at that time. There was a big shortage of it. So again, all this was, you know, no one could foresee and expect this. And it was hard to tell that group and say, look, hang in there. You are eligible for Pfizer. We are getting more Pfizer. It's just in really short supply at the moment. And Sunshine Hospital, we're not taking on any new bookings for dose 1 because they had to reserve all their current doses for people due for their dose 2. So that was really hard, and you know, we understood, we felt the pain of those people in the community. It's just the disappointment. You know, the outbreak was still quite fresh. They want to get some protection, but I guess, you know, we have to sort of sometimes take a step back, you know, outside of ourselves and our sort of, you know, concerns, and think about the big picture. You know, the big, you know, collective effort of the community, of you know, the medical professionals, basically the global effort, the national and global effort to roll out this program to save lives, because no one wants a repeat of what happened last year. And so with the vaccine, I'll touch base on, you know, how it sort of works. So obviously with any vaccine, so with vaccines, you can either get it's an inactivated virus, or it's a live virus. So COVID-19 vaccine is not a live virus. The only live virus vaccine is available is the measles vaccine, the chickenpox vaccine, the rotavirus vaccine, which is the oral one for children, and the yellow fever one. So there's not many. And so all that means is that because they have to study the virus and which way they're going to make it to enable the body to best produce the immune response that we're after. So COVID-19 vaccine is not a live vaccine, and it can't be, it can't give you COVID-19 at all. With any live virus, one of the big concerns is that people who have immunosuppression, so people who have had, cancers or any sort of rheumatoid arthritis, they are on immune suppressing medications to stop the immune system from, attacking their joints and things. Usually with the live vaccine, you can't give it to these group of people, and you have to tread very carefully. You can, sorry, I'll go back on that, you can, but you have to be very careful on their immunity level, how suppressed they are. You have to run it by their specialist, because the risk is that if you give someone who has a weakened immune system a live vaccine of something, you can give them that disease, and they can get a bit more than the disease and actually have lots of complications and cause death. So to put that aside, COVID-19 vaccine is not a live virus, so it cannot produce illness in even anyone with immunosuppression and anyone with rheumatoid arthritis or who on, immune suppressing medication. So, once inside your body, it will produce like an army, so antibody proteins to, remember the COVID virus, so that the next time if your body encounters that, it's got a whole army ready there to attack it and fight it. So COVID-19, the vaccine it protects you, is very highly effective of protecting you against severe disease, so hospitalization and death. So very effective for both of those things. But one thing that you can still get COVID. So it's not protecting us from transmission at this point. Not to say that it will never, because obviously the vaccines are still being, studied in trials, and there's going to be, I think it's going to be a very evolving space, because it might end up being that we get a new vaccine in another year's time that's better and stronger, who knows. But at the moment, the COVID vaccine is highly effective in preventing serious illness, hospitalization and death, but not transmission. So I do have insider, information where we test, obviously at IPC Health. We also have teams to test people for COVID, and I've seen the statistics, and basically anyone now who has a positive test gets asked, have you been vaccinated with COVID, a vaccine, dose 1 or 2 doses. So this data is being collected by the government, and I've seen this information from IPC Health patients as well. And there are lots who have tested positive and have been vaccinated fully. But what I have seen is that the symptoms are noted as cough, runny nose, sore throat, as opposed to, people can feel lethargy, a high fever, chills, muscle pain, and feeling very unwell. Once people get the COVID vaccine, though, I think that, there has been a bit of fear about, the side effects as well. So because it's inducing an antibody response, you can still, and the vaccine's just reacting and activating all that, you can still, and you are expected, it's normal and expected to have the side effects of fever, chills, joint pain, headache, nausea, loss of appetite. And they sound horrible, but if you actually look at the flu vaccination potential side effects, it's actually quite similar, very much the same. And in some people you might get it, much more mild than others, you just don't know. But we educate our patients that, look, in the first 2 to 3 days, you can expect to get all these symptoms: fever, pain, chills, joint muscle pain, feeling unwell, loss of appetite, and that's normal and expected, and it should all resolve after 2 or 3 days. And if you feel uncomfortable, you can take Panadol, and that helps. And if your arm's really painful, you put an ice pack there. We also, everyone gets, the information leaflet that has all that information. So what to expect, what are the less common side effects. So less common can be enlarged lymph nodes here. It's just a sign that your immune system's getting activated. Limb pain, just pain down your whole arm. Loss of appetite. So just because it's less common side effects doesn't mean it's serious. It just means, look, that it's a bit more sort of uncomfortable than the more common and milder ones, and you should be seeking your doctor's advice if you have those symptoms. Now, on the information plans as well, like I said before, it does discuss the blood clotting syndrome. So it will list the common symptoms, which is so with this blood clotting syndrome, it's not in the artery, it's actually in the veins. So it's in one of the common places in the brain. So it's different to a stroke where it happens in the artery, and the mechanism is also different, not just where it happens. It's in the cerebral venous sinus, so in the brain, where it drains in this sinus, this cavity where it drains blood down back into the body. The blood clot can also happen in the abdominal veins as well. So you can either get a really bad headache. So it's not just a mild headache that that you need to stress and think, oh, I feel a little bit of a niggle there, I wonder if it's a blood clot. No, when there's a blood clot anywhere, you start getting sort of severe, intense pain pretty quickly when it happens. That's just your body way of telling you something's blocked, something's not right. So it would be an intense headache. That's different to what, because some people say, oh, I generally get the headaches, I get migraines, but you would generally know, okay, it's a severe headache, that's not your usual thing, doesn't get relieved with Panadol, or you get severe abdominal pains, or you may get the blood clot in your legs as well. It would just be a severe pain in your leg, and it's not on the side, and both sides are different. So obviously it will just clot, it might clot in one side or the other side, but not both. If you're getting in pain, cramps both in your legs, it's unlikely it's a clot. And if, other things like blurred vision, nausea, things like that. So it is all listed there. Now, I have spoken to people in the community and others in the past where they felt like they were actually felt left alone. They've got the COVID vaccination, sent home. They felt really, really, really unwell, had nowhere to turn to. They called their GP, spoke to the receptionist who said, oh, you've got a fever, you can't come in, go get COVID tested and isolate. And, this poor woman was just stranded and thought, who is out there to help me? I've finally braved up to get this vaccine and I'm feeling so unwell. And I feel like no one cares, that no one wants me. The doctor won't even speak to me. And that was a very, very unfortunate situation where that receptionist shouldn't have said that and actually offered a telephone appointment with the doctor. But I think things have changed very quickly since, since I last spoke to this woman, because, the government and all the health practitioners are very aware of the concerns about the blood clotting. So, this is always sort of discussed and addressed at the time of your appointment for the vaccination. So there is, a checklist that we go through. The doctor, it's a nurse-led clinic, but the doctor is always around, and that's one of the criteria. A GP has to be around on site to address any concerns or ask to review. But basically, once you leave the clinic, you have all the information pamphlet, and in the information pamphlet, there are numbers to call. I don't know how other clinics do it, but at IPC, personally, I've added in an extra phone number that wasn't part of the Australian, government's pamphlet for medicine-wise, which is staffed by a pharmacist 7 days a week, 8 a.m. to 8 p.m., where you speak to them, you report the side effect, and they will help talk you through and triage basically what's going on. What are your symptoms? Is it something mild? And they can give you advice on how to manage, or if they feel it's something a bit more serious, then they will advise to call the ambulance and go to hospital. So there's that phone number. But, you know, we're spreading this message through the community as well. So even if you don't get that written on your pamphlet, you can tell everyone else, you know, call Medicine Wise, or you can call Nurse on Call and they'll direct you as well. It's a 24-hour phone number, helpline anytime. And you can also call the coronavirus hotline, which is 24 hours as well. So basically that's, you know, that's what happens in terms of after, you know, after receiving your vaccination. I might leave it there. Yeah.
There's a question from our participants and viewers. If I'm an international student, I don't have Medicare card, am I eligible to get the vaccine?
Yes, you definitely are. It's free for all people in Australia. So not free for all Australians. It's whoever's in Australia, regardless of Medicare status, you can get the COVID vaccine. However, it has to be at either the hospitals or a state vaccination clinic. And you can just look that up on the internet. You can start by clicking on the eligibility checkup, which I can email all of this through to Marissa and she can share the information as well. And it'll, you know, and basically you fill in your details, and at the end it'll say if you have Medicare, and if you don't, and you can put in your postcode, and it will show you where your nearest centre is that you can go.
Another question is, once a person is vaccinated with the 2 doses, is it okay for them not to wear masks or not social distance? Are they less likely to be contaminated, even if they don't have mask and not social distancing?
We always have to, unfortunately, at this stage, because the vaccine doesn't prevent transmission, it means you still can give it and you can still get it, even if you are fully vaccinated. What the vaccine prevents is just serious illness. So rather, if you get the COVID infection, you're more likely to have very mild symptoms or no symptoms at all. So yes, to prevent getting it in the first place, we still have to do the PPE and mask, you know, regular hand washing and sanitizing.
And with the new Delta variant that's scaring Sydney, and we've just had a scare in Victoria, will our present vaccines protect us from it?
Yes, there's evidence to show that it does have some protection against the Delta virus. It does. In terms of percentage and how effective, we're not sure, but it does give protection. So again, you know, instead of getting a very severe symptoms from it, you'll get mild symptoms.
Now, most of our families from overseas got the Sinovac or, you know, other kinds of the vaccine, not Pfizer and Astra. Will they be allowed to come into Australia if what they got is not Astra or Pfizer?
Yes. That wouldn't be, I guess, obviously when the government opens their borders, you know, that's obviously up to them, and they have to make sure that, you know, there's minimal spread in Australia and obviously overseas where you're coming from as well. So they have to look at both sides. But when they do decide to open up the borders, it will not be dependent on what type of vaccine. That any vaccine that you've got that's COVID, it's been approved, that should be that's enough. That's not a problem for them to get through.
And if the family from overseas have had the 2 vaccines, will they still be required to do the 14-day quarantine, or as long as they are negative, they can be allowed?
Yes, I'm not too sure about that. Are you thinking about currently right now, or sort of in the future? Right now.
Yeah.
Now, what country are the family members coming from?
So, for example, we're from the Philippines. If they've had 2 doses of the vaccine and they come in to Australia, do they still have to do the 14-day quarantine, or as long as they're negative, they can be allowed to come out of quarantine?
I think I'll have to double check. I don't, you know, it's not dependent on the vaccine. I think because you can still carry the virus and you can still pass it on to others. So it won't be dependent. It will just be dependent on the current government's advice about the risk in Australia and the risks in the Philippines. Like if there's community transmission, community transmission there, that's what will be the factor in deciding whether people from the Philippines need to quarantine for 2 weeks when they come to Australia. Yeah, so I think it's just about staying up to date with that advice. What is it like in the Philippines now, Marissa? Do you know the transmission and the COVID space? Oh,
it's not too good.
yeah.
The numbers are quite high.
Yes.
Also, we have an international student with currently having chemotherapy with cancer. So, what is the medical requirement for people on chemo because their immune system is low?
Yes.
Must they, or should they wait for the
Yes.
chemo to finish?
Yeah, so all people, including people who are on chemotherapy, so all people immunosuppressed are actually more likely to get very unwell or die from COVID vaccination. So the advice is yes, you should get it. But in terms of timing, that's actually an important factor in. So best to speak with your specialist about that, about the timing, because you know, sometimes they may want to time it before the chemotherapy, because once you have the chemotherapy, that's when your immune system's at the lowest. And that means that maybe the COVID vaccination may not actually activate and have a better, higher response than those who have a normal immune system. So they might need to time it before the chemo, possibly. So, you know, I can't be too specific or answer that 100%, but what I do know is the timing of it is a factor, and it's best advised from the specialist, from the oncologist.
Okay. Now, if there are any other questions from the group, otherwise we'll say goodbye to Jessica and thank her for her time. Is there any other questions, team? Okay. I know it's your mom's birthday, Jess, so thank you for... there is one more question that just came in. This will be the last. My housemate went to Sydney last Wednesday and back tomorrow. Does she need to do quarantine? For how long? And shall I ask her not to stay with me so as not to put me at risk? So the housemate is in Sydney right now and she's coming back tomorrow. Does she need to quarantine?
Is she allowed? Because I thought I heard that Sydney's in lockdown. I don't think she's allowed.
The borders are closed. So
they're closed, yes.
When they say borders are closed, Victorians that are in Sydney are not allowed to come home? Or they will quarantine?
I'm actually not too sure. I think it's just very, very restricted. So I think because basically they're, you know, you're right, they would be allowed subject to quarantine. But obviously with the quarantine, you'd have to pay yourself if it's a hotel. I'm not sure. I think the changing, you know, I think the government is looking to home quarantine. Like if you've got a home that you live on your own and not with housemates and risking anybody else, you can go home and quarantine your house. But obviously there would be sort of some sort of checking in process where they'd have to make sure that, you know, you don't leave the house. So that's something that the government's working on. A new program rather than the hotel, because obviously with the hotel, everyone has to pay for themselves. So people who are stuck in Sydney or overseas, they'll be like, you know, I don't have money to pay for 2 weeks. I'll just stay here where I am and obviously wait till things settle and go back. Yeah. So it's tough. I think they are building a new quarantine facility, which will be sort of much better and actually purpose built. So, you know, the ventilations are not going to cross, you know, it's going to be much more better setting to contain coronavirus for returned travellers.
So last question, Jess. Those who have had COVID in the past, like last year, do they still need to be vaccinated or are they immune to COVID now?
Very, very good question. Studies, you know, obviously it's all very new, but it's shown that people who've had COVID-19 infection have some sort of immunity which lasts up to 6 months. So the advice is if you've had COVID-19 infection in the last 6 months, you don't have to get the vaccine. You can wait at about 6 months to get it. But that's not to say if if we're in the middle of a pandemic and the risks is still out there and you're at 3 to 4 months, you still can get vaccinated within that 6-month period.
And Tien, your question is, yes, international students with no medical conditions, with no Medicare, can get vaccinated. We just have to wait for your turn, because it's the older people first and those in the frontliners. So you will have your turn. So thank you very much for tonight, Jess. And we wish you well. Keep safe at IPC. We know you're always in the firing line. Thank you to all who joined us tonight, and those we are live streaming this. So those who have are going to watch this even after today, they can still send in their questions, and I'll pass them on to you, and we will endeavor to answer them. Have a good night, everyone. Thank you.
Absolutely.
Keep safe. And if you don't feel well, please get yourself tested. Find Jess at IPC Health in Dearborn.
Definitely.
But, get that vaccine, because that's the only way we can all be safe. Good night, everyone.
Right.
And we can all say good night all together. Good night, everyone.
Good
Good night. Thank you. Thanks so much for having me.